in the heart or cardiovascular system of children and adults. As you know from your OB lectures, there were differences. There is a great difference between the fetal circulation and that of adult circulation, and that of circulation once the child is born. So we will have to kind of highlight those differences, because these are things you need to know. Not only knowing it for OB, you also need to know that in Peds. Okay, so you have to kind of pull it, flag it if you didn't remember what they were from your OB, just pull it up again and review them, because it will come back to you, maybe in this class, maybe in OB, or maybe in any other exam that you will take, because they will ask you to do that. So we'll also have to identify some of the common cardiac and hematologic disorders, blood and heart disorders that are common in children. We'll have to determine a priority assessment and intervention that we can put in place when we are caring for a child who has a cardiac or blood disorder. Because as you know, you have to do something for your patient, but again, we want to know of all the things that we are doing for our patient, which ones are the most important things that we need to do. We need to plan them up. Be the first things that we do, and then other things that are important to do, we'll just throw those in. We will also have to, with that, we'll need to generate a care plan, or you'll be able to, when you are making your care plan, be able to plan a care for the patient that has a heart and or blood disorder, including the teaching that you will give to the patient and or their family. Okay. So that's what we're doing, that's where we're going for this morning. So to begin with that, I'm going with the cardiovascular system. I'm doing the heart first, and then I'll do the blood system. So we know that there is a difference between the circulation in extrauterine life and that in the uterus. That's what we know. But before I go there, I just want to point out to you the differences in the heart of the child versus adult. As with any other thing that is developing during development stage, the heart and the great vessels will develop as from the 3rd to 8th weeks of gestation. Will start developing. You will notice that the heart sound that you will hear in infancy, it's of very high pitch and of greater intensity as you will hear in older children or adults. The heart rate is also faster. If you do the epical heart rate, it's fast. You check the pulse rate, it's fast in comparison to that of older children and adults. So in other words, as the child grows and matures and gets older, the heart rate will continue to decline. So it will start with a very high rate, and then it will continue to decline as the person grows and as the person reaches adult or hood. You will also notice that the chest wall of the infant and children is very thin. That if you look closely, you may be able to see the outline of the whole organs and the chest cavity, including the heart. It's very thin wall. Another thing is that the neonates in the neonatal period and infancy, their stroke volume, which means that their force at which the left ventricle pushes blood into the systemic circulation, is not as effective or as efficient as it is in an older child or in an adult. Another thing also that you will notice in that in children and infants is that, especially in utero, there is increase in pulmonary circulation. That the pulmonary circulation is very high because the lungs are collapsed. We don't have any air exchange in the lungs, and they are filled with fuel. So which means the resistance of that circulation is very high, it's increased. Pulmonary resistance to pulmonary circulation is increased, it's high. Another thing, yes?
Can you repeat that again? The lungs are filled with fluid.
The lung is filled with fluid. There is no air exchange in utero, and which we will point out when we go to there, when we trace the blood flow through the heart. Okay? Another thing you will notice also will be that for children, and the younger they are, the more you will see this phenomenon, is that in the face of shock, you may still notice that the cardiac output is still normal, even though that child is in shock. And we're saying that shock and cardiac arrest in children will be preceded by respiratory arrest. You have respiratory failure before you have a cardiac arrest in a child or infant. But in the adult, it's the reverse. You have cardiac arrest, and then you have respiratory failure. But in infant, it's the flip. Because we said that shock may be still present, and the heart rate and the blood pressure will still look like it's normal in infants and younger children, when you notice a decrease in blood pressure in an infant or in a child, that will be a late sign for that child. The child must have, attempted to compensate for the problem, and then, so they're just like, it's a very late clinical symptom that you will notice, decrease in blood pressure. So in other words, what would you like to see? Initially, you would like to see that when you see that increase in heart rate, much more that you will see at their baseline. So tachycardia, tachypnea, you would like to act on those at the initial stage, because if you start looking at when the blood pressure will drop, for you to say, oh, this patient is really in trouble, or to note when there is decline in the heart rate, then you have lost the patient. Okay? So, you guys did anatomy and physiology 1 and 2, and you did, so with that, what is the normal part of blood flow in the heart? From your anatomy and physiology. I'm not talking about in utero. Let's do the plain old one that we all know. What is the part of flow? You can get it from the diagram also. What is it? So can one person volunteer to give us the outline? Who is volunteering? So that we can get it. All right, Timothy? Yes.
Karen track.
Yeah, sure.
Enters from the blood, deoxygenated blood enters from the superior into the right atrium, which then enters the right ventricle through the tricuspid valve, and from there it goes into the pulmonary artery to the lungs where it becomes oxygenated, then back into the heart, the into the left atrium, then passes through the mitral valve into the left ventricle, which then goes into
So, all right. So, so in other words, the blood flows from the head, from the heart, into the right atrium, through the mitral valve to the right ventricle. No, tricuspid valve to the right ventricle, and then it goes where? Pulmonary. Through where? When? Huh? Through the
pulmonic valve.
pulmonary valve to the lung. Okay, so when it gets to the lung, it will pick up oxygen. Okay? And then once it gets the oxygen, then what happens? It comes back to where? Okay, from the pulmonary vein to where? To the left atrium, from the left atrium. Okay. That's why I was going to ask you, what is the role of the aorta?
It's to carry the blood to the body. Oxygen.
Okay. So, but while the child is in the uterus, it's different. Child is connected to the umbilical, to the mom through the placenta. And from your OB, what did you learn? Because you did that in OB.
That the umbilical cord is there with oxygen and it has two arteries.
The umbilical artery has deoxygenated or oxygenated blood.
I don't know.
Hmm?
It's both.
Okay. The umbilical artery carries deoxygenated blood from the placenta, so there is the blood that is carrying is diminished of oxygen. Okay? So it carries that blood from the placenta and gets, takes the blood to the placenta, and the blood is, transferred there via diffusion will transfer the nutrients and oxygen through that exchange. And then the oxygenated blood now goes to the umbilical vein. So you know that the arteries will carry blood that is deficient of oxygen, while the veins will carry blood that has oxygen in it and nutrients. So that one from the umbilical vein will go through the liver into the inferior vena cava. And then it will pass through the ductus venosus that is located in the liver. So that will shunt the blood away directly into the inferior vena cava. So with that shunting of that ductus venosus, the blood does not really get into the hepatic arteries. So other things that you will see is that there will be 3 shunts that you need to know. The first one will be the foramen ovale, which is this shunt here. And the foramen ovale is connected to the it's in the atrium. It's in the septum of the atrium. And because there is that opening in that septum of the atrium, you will hear them referring to that as a hole in the heart, because that allows for that exchange of blood from the right to the left side of the heart, because of that channel there. Once the child is born, that hole usually will close, but sometimes it does not, it will remain open. The other one you will notice will be the ductus arteriosus. This one here, which is that shunt between the aorta and the pulmonary vessel. Right here. In extrauterine life, that opening is closed, and it just converts to a ligament, and there is no blood exchange between the aorta and the pulmonary artery. However, in utero, there is that opening, that shunt. And what this shunt does is that it will shunt away the blood that goes to the lung. Because remember, we said there is no blood exchange in the lung. Another one that you will notice will be that opening between the ventricle that allows, mixture of blood in those ventricles. So you have the intraventricular shunt with the foramen ovale, which is in the atrium, and also the ductus arteriosus that is at the arch of the aorta. Other things that happens in the heart that we all know about is the conduction of the electrical conduction in the heart. So starting from the atrium, we have the sinoarterial node, which is the natural pacemaker of the heart. That's where all the stimulations will start. And then it starts here, it goes to the AV node, which is the next junction. And then from there, it will go down through the Purkinje fibers, and it will get spread to all the other parts of the heart. And this is what you will see, this movement of the electrical impulses is what you will see on that EKG strip. The p-value will be that initial arterial node. The QRS complex will be that transfer of that AV node to the Purkinje fibers, and then your T wave will be that resting phase. So as that impulse travels through the heart, the heart is able to polarize and able to rest in between those activities. So both the blood flow and the electrical impulse happen simultaneously in the heart. So for us, placing a lead on that child, we would like to place it, and we usually use the standard lead 2. That's what we will use in the child. And we will put it on the right and left chest wall, and then the left leg. So looking at the child, you can place it on the chest. The left leg can be anywhere below the chest cavity. It could be on the leg, it could be on the abdomen, because it will pick up the rhythm for you. And this thing is color coded, that you will know also. You look at the colors to tell you which one goes with. So, having said that and having done that quick review, we need to look at indicators for cardiac dysfunction in a child, because these are the things that you would like to know ahead of time, or not be cognizant about. That way you'll be able to care for your child. One of the initial things that you will notice will be that that child has, is not feeding well. Child is refusing food. Child can be irritable, but again, you know that other things can make the child feel the same way. Child may have tachypnea, tachycardia. Again, looking at other things that, respiratory problems can also make the child have increase in heartbeat, increase in respiration. So you're not, at that point in time, you are not really sure, but you know there is something going on, okay? Because that child is not feeding well, that child will end up with failure to thrive, or that child will start losing weight, or that child will start having problem with that, tolerating activities. Okay, just trying to feed that child, you see that the child will just talk and talk and talk. They're not feeding, they're not eating, and they just get tired, or they can break out in sweat just for the fact that they want to eat, or just for the fact they want to make a bowel movement to break out in sweat. So a little activity kind of bothers them. Then we say, this child is not really doing well, because if all these little things that they should be able to do normally is bothering them, then there is a problem somewhere. Okay. And again, if a child is not eating, what follows is, they have developmental delays because they're not getting enough nutrients, and that will aid the growth of the body systems. Remember, we said in infant period, it's, you have the rapid growth of all the cells of the system that will grow rapidly. And the next time you'll see a rapid growth will be in adolescence. Every other time in between will be just like a slow, steady pace of growth. Another function thing you will notice will be based on the prenatal history that you're getting from the parent. If that mom has a cardiac problem, or the mom has any infection that could that affected the well-being of the mom, especially those infections that can occur during that sensitive period of gestational development, that can lead to congenital problems. Or maybe you have a cardiac family history of cardiac problems, and some of those problems can grow in families. Some of the things that we'll do by diagnostic evaluations will include chest X-ray. We love chest X-ray just to give us a baseline. In that chest X-ray, you're looking at the picture of the heart. To give you an outline of the heart, to give you an outline of all the structures on the chest cavity, including the lungs, whether there is inflation of the lungs or inflation, or there is something fluid in the lung or anything. It will show you, give you an outline of that on the chest X-ray. The EKG, ECG will give you the electrical impulse that goes in the heart, while the echocardiogram is just like an ultrasound of the heart that will give you the picture of the heart and the structure. Sometimes under interventional radiology, they'll have to do the angiogram with or without contrast, and they will inject the contrast dye just to be able to, once they inject the contrast dye, they'll go in and look under fluoroscopy, they'll be able to see the dye, outline the vessels of the child. And they'll be able to detect, so depending on the path of flow of the dye, will tell you, oh, okay, it's not flowing the normal way, okay, it came to this place and then made a shunt or have a bypass, which means that it's not flowing the way it is supposed to be flowing. And then, as always, they will do a cardiac catheterization, which is also something they do in the interventional radiology. And that is a very common procedure that they do in children and who have cardiac problems, which you need to know about. So because of that, I kind of put in a separate slide on cardiac catheterization. Because with that, you go under conscious sedation. You have to prep the child. Child is usually MPO at least 4 hours before the procedure. They'll have to do the procedure under conscious sedation. And what the cardiac cath does, it will give you an outline of the heart and the vessel. And the physician will be able, the cardiologist will be able to take their pictures to be able to say, okay, this is where the problem is for this child. Sometimes they will use it to correct cardiac problems when they put a stent. When they do the patch for the ASD or PSD, or so they can use it to put the patch on. But pre-operatively, we need to prepare this patient. We need to teach the parents about what is going to happen, and or do an age-appropriate teaching, because sometimes the heart problem may not be evident in the immediate newborn period, and then the child grows maybe like a preschool, school-age child, or even bigger before they notice the problem, and then they needed to do cardiac cath to figure out what is going on. Okay. So another important thing they need to do will be to do a blood work. And that blood work, they need to do the complete blood count, including their prothrombin time. They need to do that because when they go in to do the procedure, they are making a hole in the femoral artery, and that's a very big, large vessel, and you can run a potential of injury post-operatively. Okay? So you need to kind of know where the patient is at in terms of clotting factor. If that patient is on aspirin or taking anything like blood thinner, that has to stop before the procedure. Another important thing that they will do is to look at the child extremity, which one they are going to use, or sometimes the physicians will mark off both. They look at the pedal area, they'll feel the pulse there, and they'll use their marker to mark where they felt that pulse of the greatest intensity of that pulse, because immediately post-operatively, you may not be able to feel the pulse. So in that instance, at least you know where that pulse was much stronger. Pre-operatively, you can go there to feel it. If you can't palpate it, they usually use a Doppler to make sure they isolate that pulse. Because when they go in, there could be a potential of that person going into cardiac arrhythmia, or the blood vessels will go into spasm, and you will not be able to feel the pulse for a very long time, or not at all. And when there is no pulse, you need to act on it, because that can put the patient in danger. So, having done all the prep, don't forget that the mom or the parents have to sign the consent to do that. So the physician will explain to them and they'll sign the consent. Sometimes after they sign the consent, they'll come to the say, gee, what did he say again about the procedure? And then if you try to explain to the mom in simple terms what the procedure is about, and they still have a lot of questions regarding that procedure, please bring back the physician to re-explain to them, because if they don't understand the procedure, and they are signing, they are not really, it's no longer informed consent, because that consent is supposed to be informed for them to really carry out that, go willingly for that procedure. So they have to bring back the consent, bring back the physician to have them re-explain. But on every unit, there is a teaching tool that is simply written at the grade level of 5, so that it's simple enough for them to understand. But sometimes it's not that easy for them to really articulate or to really understand what they are saying, especially when they have they don't speak English. So you need to give them a literature that is in their own language. One thing that I found out is that somebody speaks a language fluently does not translate or does not equate to the person can read that language fluently, can read the language and articulate and understand the language. It's not the same. Because I found that frequently, and I use myself as an example. Even my dialect, I can speak my dialect very well, but there are things that sometimes you look at it, I read them like, what is it? How do we pronounce this word again? Or what is that meaning? And I go through that all the time with my kids. They go to me, Mommy, you said this, I know what you said, but how do we read this? So the same thing will go to any other person from any other country that have a language and you think that they are fluent in it, they can read it. No. It doesn't work that way. So you really have to make sure that they really understood it. So that's why that phone, blue phone, um, comes in place, or you get an appropriate interpreter. So post-operatively, that child, this instruction will start in the pre-op period. You have to tell the parents and the child that their leg has to keep the leg straight for at least 4 hours post-procedure. They cannot bend the leg. It has to be kept straight. Okay? And explaining to a child that you have to keep their leg straight, it's a toughie, because they can't do whatever, do their thing, but the parents will have to help to constantly remind this child. If it's a younger child, the parents can hold the child and, and also be a reminder for the child to keep their legs straight. For us, we need to monitor the IV intake and output of that child. Monitoring of bleeding, if that child is bleeding, we need to know it. The immediate post-operative, the dressing, the initial dressing, we don't take it off. In fact, as a matter of fact, all surgical dressings, the initial ones should be taken off by the surgeon that puts that dressing on. But these days, I'm seeing some of the surgeons that will just say, you can do whatever you want with my dressing. But I know in those days, surgeons will touch their dressing, the initial time, they'll get your head in a platter of gold, because they will not be happy about it. However, there are some of these newer ones that will just go to the station, you can do whatever, but that's not true. Do not touch the dressing unless you are told to. If there is a bleeding, get your 4x4 or combined dressing, reinforce that dressing, and just notify them, your patient is bleeding. You notice blood on that, on the wound, on the incision side, but please do not leave it open. Just reinforce the dressing and don't leave it open, unless you are giving the express permission to do so. Okay? So, you need to monitor for cardiac arrhythmia, because you remember they use their probe to go in to the heart vessel, so that can trigger off arrhythmia. Infection and pain management is also included. And then you want to monitor, make sure that that child is voided. Intake and output is very important, because they put in a guy. You want to make sure that the child is excluding that guy as well. So these are things that you really have to look out for when a child had cardiac cath. Any questions for cardiac cath? Okay. So for cardiac cath, you will definitely get questions from it. That one is a given. No exam will you escape getting a question or the care you will give for a patient that had a cardiac cath. But again, for those questions, you have to look at what you need to be doing for your patient. That dressing, okay, when the child goes home, the mom will ask, okay, on this child, when do we go back to school? Well, usually the cardiologist will tell them, some of them will say 3 days, after 3 days. Some will say longer, depending on how the child feels. Okay? But it is very important for them to go back for that cardiology follow-up care. You have to emphasize that they need to go back, to come back for cardiology care. Okay. Any questions? So for congenital heart defects, we have cardiac defects which will be congenital, and those will be those anatomic problems that child was born with, or they can be acquired. It could be a disease process, it could be autoimmune, It could be from environmental, it could be from, from infection, okay? So, for the congenital heart disease, it would say that about 1 to 2% of them is from maternal causes or environmental, something like drug use or alcohol use in the mom. Kids, mom that has, fetal alcohol syndrome, those kids most of the time will develop heart problems. And this is just simply because during that sensitive period of development, mom was using alcohol and that kind of makes them, not to develop as a whole. Some of the other things will be maternal illnesses, which I just listed here, or chromosomal or genetic defects, which will account for 10 to 12% of it, and then other ones will be a combination of both maternal, chromosomal, or anything environmental condition that can lead to that, which is the big chunk of the cardiac problems that we see. Pretty common, about 8 per 1,000. And some of them, most of them will be, show symptoms the first year of life. Cardiac problems have been documented as one of the causes of premature labor. Most common one would be the ventricular septal defect. And again, 28% of children who have congenital heart defect will have another form of congenital abnormality, something like trisomy 21 or 18 or Down syndrome or anything like that, or Prader-Willi syndrome. So, for the congenital heart defects, we have classifications of them. Initially, the American Cardiology Association was defining it as per the oxygenation of the blood that goes through the body. But they found out that with classifying it to that, some of those, sometimes that patient may not be truly cyanotic, or sometimes they are really, they are supposed to have, tongue blue, but they're not really because of the way their body is compensated. So, but anyway, I put this here so that you will be aware of it, that there was an old classification, and then I'll do a comparison between old and new, which you will see that they all fall in place as I said. So, the older one would be based on acyanotic, meaning that when blood flows from the arterial system to the venous system, so the arteries will carry the blood that has no oxygen in it and dump it in the vein, in the ventricle, and that will get into the systemic circulation. So in other words, that artery, the blood in that artery did not get into the pulmonary vein. Because for it to get into the pulmonary vein, it has to go into the lungs to exchange carbon dioxide for oxygen, and then take that out to dump into the ventricle for it to go to the systemic circulation. But in this instance, that does not happen. That blood did not make it into the lungs. Okay, so what happened is that, there is that shunting. Instead of it going through the lungs, it didn't go. So now what you see is that no oxygenated blood enters the systemic circulation, because that's what is giving that child the overall color of blue or pink. Some of those ones that would have the cyanotic defect would, and then it will be the problems that will shunt the blood from the venous through the arterial system. Cyanotic, there is no entry into the lungs. Acyanotic, blood goes into the lungs to pick up oxygen. Okay? So in other words, the blood that goes into the systemic circulation is fully loaded with oxygen. That's acyanotic, meaning that that child is nice and pink because there was that exchange. Now, cyanotic, on the other hand, there is no exchange of blood. Blood is not getting to the pulmonary vasculature, it is not exchanged, and because of that, the whole blood that is getting into the systemic circulation is deficient of oxygen, so the person will turn blue. So, how do we measure cyanosis in cardiology? We'll say that we're looking at parameters of 95 to 98% will be normal. And for a child that has 90 to 94, we'll classify that as mild hypoxia. Moderate will be anywhere from 85 to 90, and very severe will be 85. However, the cardiologists will write their own specific parameters for each individual child, and the way they will write that order, they may send to you to give blow-by oxygen or X number of liters per minute to maintain O2 sat to this level. They will write that specific order for that particular child. But the general parameter overall standard will be what this is what it is, but the specific ones will be per individual patient and per each individual cardiologist. Right. So this brings us to the newer one. So now, because of that, how do we define hypoxia? Because each person will kind of write their own thing. So we said, okay. So now they sat together and decided to reclassify congenital heart defect by the hemodynamic characteristics of those conditions. Ones that will increase pulmonary blood flow, or ones that will decrease blood flow, or ones that will result as a result of obstruction of blood out of the heart or mixed blood flow. So with that, looking at this here, we put it as acyanotic and cyanotic, which is our old classification. Now the newer one will be those conditions that will result in increase in blood flow to the lungs, because there is a lot of blood getting into the lungs, or there is one that will obstruct blood entry into the ventricles. So these two conditions, these are the newer ones, which they refer to as acyanotic before, and that was because of that directional flow of the blood, they reclassified it. So some of the conditions that will result in increase in blood flow to the heart will be when there is a hole in either the septum of the atrium or the ventricle, or when there is that opening between the aorta and the pulmonary artery, that one that will prevent blood from getting into the pulmonary vein, or when there is atrioventricular canal. That one is, so that's what will cause increased blood flow into the pulmonary vessel. On the other hand, when there is flow into that pulmonary vessel, but blood that gets into the ventricles is kind of slow for some reason, that blood went all the way to the lungs, gathered oxygen, but going back to the ventricles is kind of slowed down. One common one that we all should know will be that coarctation of the aorta, where there is a kink on the arch of the aorta. That kind of slows down blood getting into the systemic circulation. And with that particular condition, you will have that, you know that there is a discrepancy between the blood pressure on the arm and the leg and the lower extremities, or even the pulse pressure will be different. And that's one of the things that they would like to note in the immediate newborn period. Okay. On the other hand, the ones that are cyanotic are the ones that have less blood oxygen getting into the systemic circulation. So there is less flow of blood that goes into the lungs to pick up oxygen. One of that will be the tetralogy of Fallot that has 4 deformities, or any narrowing of the tricuspid valve. Sometimes you have mixed blood flow, that blood goes in any direction. And with that, you have mixture of blood freely, blood that's supposed to go from left to right, that shouldn't mix up initially. Everything is just mixing up, so it's like siding flow. So now you have transposition of the great arteries, or hypoplastic heart syndrome, where the left heart did not develop fully. Okay. So these are the newer classifications, and just for you to know that it's something that you need to be aware of. So, taking them one at a time, those defects that will increase blood flow to the lungs. Yes.
I'm sorry. You were mentioning a discrepancy of pulse pressure. Can you specify?
I'm coming.
Oh.
Coarctation of the aorta, I'll deal with that too. Okay? So, taking these conditions differently, because that one I put a separate listing on it because it's something that you need to know. Right? So, with the increase in blood flow, so you have that abnormal connection between the two sides of the heart. It's either on the atrium, on the ventricle, or the blood vessels, but those two sides are mixing. You have increase in blood on the right side of the heart. The blood that goes into the pulmonary arteries increased also. The pressure is high because the blood goes there to pick up oxygen. But because of that opening in that either the atrium or the ventricle, so now the ventricle or the atrium is not, holding the full capacity of blood that it should hold, especially with the ventricle, and you will see that when we do the ventricular septum defect. So which means that the force of blood that would go into the pulmonary vessel, into the systemic circulation is decreased. So you have atrial septal defect, the ventricular septal defect, or the ductus arteriosus or AV canal. Okay. So now these are those deformities. So this is on the atrium. This is the patent ductus arteriosus, and this is that opening in the ventricle. So for that ventricular septal defect, that one is something that is very significant most of the time. The blood that enters the aorta is very, very well loaded with oxygen. It has oxygen in it, and it flows into the ventricle. But because there is a leak in the ventricle, just imagine that you have your container and you are filling it up, but because there is a leak in it, it's not filling to its capacity. And also because there is that defect in that ventricle, the ventricle is not pumping effectively as it should to shoot the blood into the systemic circulation. So the problem here with the ventricular septal defect will be on the ventricle failure as a pump, because every other thing is fine, but the blood goes into it that is fine, but because there is that leak, it's like you have a slow leak in your tire. Okay, you still be able to drive, but there is that slow leak, so which is kind of slowly, slowing you down, or you have like a partial clogged drain. Okay, water will still be able to flow, but it's not as efficient as it should be. Or you're trying to water your garden, you pinch it somehow, and you expect you want to shoot water to the rest of the of your lawn, but you have a kink somewhere. Yes, water will flow, but it will not reach the area that you want it to reach. So just think about it, picture it that way, because that's what is happening in the ventricle. So the problem with that will be failure of that ventricle as a pump, not any other thing. Okay, so child will have, again, all those characteristics we said about problem with difficulty feeding and heart problem. Okay, again, this condition can be closed. We prepare the child for surgery, and including the teaching and everything that we have to do, and then post-operative management. We would like to look at both, the side, who are immediate post-op vital signs and recovery of intake and output and all that, and give medications and everything we have to do for that particular child. Okay. Another one would be that cotton ductal saturosis. Again, failure of that to close at birth. Sometimes it will close by first week of life, sometimes it will not. Characteristics, you hear that machine-like murmur. Okay. Management, usually they will give indomethacin or indocin to help facilitate the closure. Okay. But when they try the medication and it's not closing, they may go in to do surgery to just use a patch to close it. And then, of course, you do your post-op management as well. But the key thing is that they can do non-surgical procedure by giving medication in the sleep to close it, or they do surgical procedure to close it. Now, when there is an obstruction, here you see that the aorta is narrowed. It's not as fully as it should be. Or you see this narrowing on the pulmonary vessel, or you see this one in the aorta, arch of the aorta. Okay, this coarctation of the aorta is very significant in newborns, and we need to know about it. Okay, because that is the narrowing of that narrowing at the arch of the aorta. In the immediate newborn period, most hospitals will have it as a policy to do 4-point blood pressure on the immediate newborn period. Or if there is a suspicion of problem, the physician can order for you to do a 4-point blood pressure. And when they order that 4-point blood pressure, they're just trying to assess, the pressures on all 4 extremities. What you will notice is that when you do that, there is a difference between the upper arm pressure than that of the lower arm because of that narrowing and that edge of the aorta. When you feel the pulses on the radial pulses will be fuller and more bounding than they are on the extremities, including the femoral pulses. So once you notice that differences between the pulses or blood pressure in the arm and in the leg, you will know there is a problem. Sometimes it's as much as more than 10 to 20 millimeters of mercury difference in the blood pressure that you get from the arm and from the leg. Okay? Sometimes another thing is that patients will complain of pain or the child will be irritable, especially when you touch the leg. Legs may look cyanotic sometimes. Or when you look and when you try to assess for the capillary refill, you see that the capillary refill on the lower extremity is much more sluggish than you do when you do it on the finger. Okay? Because of that sluggish of blood and backlog of blood, that patient will start developing congestive heart failure. Okay? So again, intervention they want to do, they can do under interventional radiology, they can put do an angioplasty or put a stent to kind of keep that narrowing open. And then again, we need to do our own pre-op and post-operative surgery. Again, this patient has a very high risk for bacterial infection because of that sluggish. Once there is stasis of blood or fluid or anything in the body, then you run the risk of having increase in infection. So this person will have to need to get prophylactic antibiotics for any procedure because of that risk of some bacterial endocarditis. Timothy, does that answer your question? Yes, clear now? Okay, yes, please.
So you said the upper extremity, the pulses will be fuller and bounding, and the lower will be. Is that what you said?
Yes, there has to be a difference between the two pulses. Any other question? Yes. Timothy?
Oh, yeah. Just a question about the VS3. Would you be expecting that patient that's be cyanotic, right? So the patient will be.
So the problem with that patient is that the ventricle is not pumping forcefully. Yeah. The blood that is there has oxygen as anything but just because it's sluggish and the ventricle is not as efficient yet. That's why, because if the blood that got in that ventricle is deficient of oxygen, then all it's pumping to the systemic circulation is blood that has no oxygen. It's here, but the flow is less. Yeah. Any other question? Any other question? Okay. All right. The other ones will be the ones that will cause decrease in pulmonary vessel blood flow. Here will be, see here, the tricuspid valve did not develop. It's just like a blind spot or just very narrowing. Peter didn't develop. So the whole blood that is supposed to get into the pulmonary vessel is not going in. Go there. On the other hand, here you have 4 deformities here. Number 1 would be there is this stenosis narrowing in the pulmonary vessel right here. When you look here also, you see the right ventricle is hypertrophic compared to the normal right ventricle here. This is kind of over hypertrophic here. If you look here also, you have that opening between the two ventricles. They shouldn't be mixing up. Okay? And then another thing you have here is that the aorta, instead of the aorta arising from the right side, from the left side, it's arising from the right here. Right. Okay. So with that problem, so you have these 4 deformities which you need to know. The tetralogy of Fallot was named after the physician that was described it. So it has pulmonic stenosis, right ventricular hypertrophy, ventricular septal defect, and overriding of the aorta. So what happens to this patient is that the patient will present with cyanosis. And because that patient is cyanotic, the body, in attempt to compensate, will say, okay, I am lacking oxygen. I need to make extra red blood cells, because you know that the function of the red blood cells will be to carry oxygen to the body. So the body will say, okay, now let me make extra red blood cells because I'm low in oxygen. And with that making of new red blood cells, you have a lot of red blood cells, and that is what is referred to as polycythemia. And this polycythemia has a significance in children also if in the face of dehydration and you have all these red blood cells clogging the cells, that can have an implication on the children also, that can lead to a stroke, because those blood cells are just clogging the capillaries. So what this patient will do is that the patient will try to compensate, and that is what we refer to as that third spell. Periodically, they will go into periods of cyanosis, and they will try to compensate by squatting. And you will see the children will just do it on their own. You don't even have to tell them. They are getting into trouble. They either squat, they go into knee-chest position, or they can squat. So if you see a child in that third spell, or just for some reason just went into knee-chest position, leave the child alone. If that child has cardiac problem, just leave the child alone. The child will recover. Or if you are doing your vital signs and all of a sudden your child just decompensated, you see that they become so cyanotic all of a sudden, and you know that the child has a cardiac problem, put the child in a knee-chest position. Put the head lower down and let the child pick up. Okay. Others, you notice other signs of chronic hypoxia because that child is consistently cyanotic. You will see that the child has dyspnea, there is clubbing of the fingers, exercise intolerance, and failure to thrive. These are all late signs of chronic hypoxia. Again, you can have mixed blood flow. Here, the blood in the aorta is cyanotic. So they have like mixed blood flow, so there is this transmission of the blood vessels here. The aorta is rising from here instead of here, the pulmonary artery is rising from there. Another thing will be that hypoplastic left ventricle. See, the left ventricle is not existing here. Okay. So with this, we just highlighted the new common ones that you will have to come across. Patent duct they must know once patent doxycytidine and the care that you need to give, ventricular septal defect, atrial septal defect, and your pathology of follow-up. You need to know those and what they are and what and coaptation of the aorta. Every other thing in between, yes, you can know them, but these 5 is a must know.
Do you mind repeating that, please?
Huh?
Do you mind repeating those 5? Please.
They're on the slide, separate on their own. Coaptation of the aorta, ventricular septal defect, atrial septal defect, patent doxycytidine, and pathology of follow-up. You must know these 5, and each of them have a specific care that you need to give. So, nursing management in general for a child with congenital heart defect, our strategy, our goal would be, we need to improve oxygenation, we need to promote adequate nutrition, because we said that this children with heart defect will have present as failure to thrive. We need to assist the family in coping with the child that was diagnosed with heart problem. We want to prevent infection, provide patient and family education, and then if the child is going for a cardiac procedure and or cardiac surgery, we need to provide our pre and post-operative care. Okay, and again, I'm repeating this post-operative care in form of listing so that you will kind of recap what you need to know about what you need to do with post-op care. Again, complications that can happen, again, we're saying it, we talked about it when we discussed it, but again, I'm putting it down in here for you to kind of know that this is a possibility. Okay. Any questions from those congenital ones before we move to the acquired ones? Okay, so the congenital ones are those ones that the child was born with. They develop in vitro, and when the child is born, it's evident that the child is maybe very, very much evident immediately newborn that the child has it. Some of them will be after a few days you notice that the child has problems based on the symptoms or based on what the parents are noticing about the child's condition. Okay. However, the acquired ones are the ones that the child was not born, the child has a normal heart at birth, but something happened and the child developed problems. Some of those can be congenital heart failure, which is defined as that inability of that heart to maintain basic function of the body. The heart is not able to pump blood effectively to the systemic circulation to maintain the vital capacity, vital hemodynamic status of the patient. It's not able to do all that. The heart is not able to pump those nutrients to maintain the optimum status of the body, including maintaining the blood pressure, including maintaining the fluid and electrolyte balance, including maintaining everything that the body needs to do. The heart is not just able to do that, function effectively as a pump. I'm explaining this in different ways so that you get this, because it will come to you as any form of whatever, be it in an adult or in a child. Basically, what we are looking at is that that heart is not able to do its function, period. Okay? So, for us in children, and for any other patient that we take care of, we like to notice those early symptoms. Mild resting tachypnea, child has difficulty breathing, or the respiration rate is kind of high, child is trying to talk when they are not doing anything. Child will feel more comfortable when you prop the child up, or mom can say to you, you know what? When I hold him on my shoulder, hold him up on my shoulder, he feels better. As soon as I put him down, he starts to talk again. Okay. You need to find out what's going on with that child. Or the child will try to eat. They want to eat, they feel hungry, but each time you put the bottle in their mouth, too soft, they break off in sweat. Problem. Would be like, why? This is just some, or they want to move their bowel, or even to pee. They just exerting that tiny pressure to pee or to move their bowel, they break out in sweat. Something is bothering that child. So that child has not, the heart is not able to maintain that status that it should be able to do. Of course, our baby is not eating, so they will not gain weight and they will not grow as expected. You put their weight and their height on that growth chart, you see that it's way below your expectation. That child needs to be evaluated. Okay. So, clinical symptoms, I divided it based on function on the myocardium, function on the pulmonary, and function on the systemic. And this also, you can see this to be true in adults, because when they have congestive heart failure, it impacts all these areas as well. So you can transfer this to that adult, but just know that, okay, this is what may be going on. So for us, because of that impairment of the myocardium is not pumping as it should. Child has tachycardia. The heart is just trying to walk as fast as it says, thinking to itself, okay, you know what, if I walk hard, I'll be able to get this walk. And then it's going fast. With that fast beat, it's not equating to that person's energy level. That is really taken away from that person's energy. So the person is getting weaker and weaker and weaker and weaker, and then fatigue is setting in because of that overwork. You're looking at that also, the heart is pumping its way, churning its way, trying to do what it should do, but it's not effective in pumping that blood to the systemic circulation. The extremities feel cold to touch. Pulses are weak because it's not pumping out. The pressure is not enough. There is decreased blood pressure, which will be a very late sign for us in children. There is also less blood because of that pumping, and blood is not going to where it's supposed to go effectively. Blood getting into the kidneys is kind of less, and that also will impact on the function of the kidney, so you have decreased urine output. And the result will be the person is retaining fluid, okay, while they're holding on of the fluid, so the efficiency of the kidney is not up to par. In the pulmonary system, because the blood is not pushing forth in the systemic circulation, there is now a backlog. Blood that went into the pulmonary circulation wants to come back to dump into the systemic, but the systemic is not moving as it should move, So now there is a backlog. So they're coming from the lungs and they're backing up. So now, over time, you have like a hold up. It's like a traffic jam. All the way back there still, but because the person in front is not moving, they are looking at the accident on the other lane. So they are not moving, so now there is a backlog. So now there is pulmonary congestion. With that pulmonary congestion, you have increase in respiration because the body will say, okay, check. Okay, let me see. If I breathe harder, I'll be able to get this moving and then it will go. And the person is breathing harder and harder and harder. That will overall end with respiratory distress. They are cyanotic, they are exercise intolerant because that blood is simply not, the one that has oxygen is simply not getting into the systemic circulation as fast as it could. Over time, there is less oxygen to the tissues of the body. Again, with the venous congestion, again, because of that holdup, instead of going, it's all staying. So now, the food will say, no, I think I can go someplace else. It does not go through the urine, it stays in the body. So that will be that increase in intra and extracellular cells, and then you see that fluid retaining in the lungs. When you hear, listen to the lungs, there is that fluid in the lungs, there is this congestion. The nerves will start distending, and the patient will start getting weight because they are retaining fluid, and the abdomen will start getting bigger. So in other words, these symptoms you will see in a child and you will see in an adult. So how do we manage that? We would like to decrease that workload of the heart as much as we want to. Because the heart is just pumping and turning away, we would like to decrease that in order to make the work of the heart more efficient. And we can use medications to do that. Our number one medication that we like to use will be the digoxin. You have to know the digoxin in and out, front and back, left and right. Everything about the digoxin. We also need to get the fluid moving, and we give diuretics. And we also need to get the work of that heart very efficient by lowering the pressure, or the first point of doing that by using the angiotensin inhibitor. These you need to know in and out, left and right, front and back. I don't care anyhow. If you want to memorize the effects of these medications, it will come to you in Peds, it will come to you in MedSearch 1, it will come to you in MedSearch 2, it will come to you anywhere because they will want to know these medications. So for our own purposes, we have parameters where we will define bradycardia. Remember, in adults, I know you did it, in pharmacology, if you're going to give the digoxin, what do? You check the pulse rate, and when do you hold?
It's above 60.
So in children, we do the same because, yes, the digoxin therapeutic work is to slow down the rate of turning away of the heart. Yes, in order to make it more efficient, in order to increase the contractility of the heart. Okay, but in the space of where the heart is slow already, and then you give the digoxin, it will slow it further. And that's not what we want, because if you slow it further, now that heart is not even able to pump enough blood to maintain that vital capacity that we're supposed to maintain. Therefore, we have to monitor the heart rate. Okay, so For us, we have put down infant and children, any heart rate below 100. Older children, 80. Adolescents, 60. Okay? And then you need to know signs of your D toxicity. So you need to know that. Okay? And then I just gave you the parameters based on National Institute of Health, which is the parameters that is universal, that everybody uses for their baseline parameters for the child. So choose to use this one. And if I'm asking you anything, that's what I'll go by. Okay? I'll go by Institute of Health parameters. Any questions? All right. So, other things that can happen will be ineffective endocarditis, which is just like some acute bacterial infection of the heart, and this can be from stress of staphylococci or fungal infection. And sometimes it can occur when there is congenital heart problem because of that problem we have with the heart not able to move blood around. There is stasis of blood, and that can, come along with it. Sometimes it could be infection from any other part of the body that can put the person at risk. Sore throat, UTI, any other skin infection, anything can. Because remember, blood does not discriminate. What it does is whatever it sees, nutrient, non-nutrient, anything, it can take it and deposit it anywhere on the body. And that can go to the heart. Okay. So again, our symptoms will be that fever and all that with loss and symptoms that so what we would like to do would be to do the EKG, notice the EKG changes and increase in erythrocyte segmentation rate. Of course, we do a positive blood culture, which will not tell us exactly where that problem is, but we will look at the symptoms. And of course, we would like to treat the person with IV antibiotics, and then when they're going for any procedure, we do prophylactic antibiotics. Other problem will be the rheumatic heart fever, which will be Group B, Group AB hemolytic streptococcus infection, and this is one of the reasons why we need to treat sore throat effectively, because if not, that can go into affect the heart. Okay, so we don't want that to happen. As the same thing we don't want it to happen with the acute glomerular nephritis, same thing we don't want it to happen here. Most of them are self-limiting, that you have, swelling or pain in the joint. Okay, but when it gets complicated, then now the person will flip to rheumatic heart disease. Okay, so the initial infection, when it's not treated completely or it did not resolve completely, then it can lead to damage to the heart valve. It could be mitral valve, it could be tricuspid valve, it could be, any of the valves of the heart affect. The narrow valve, anything. Okay, so what the patient has will be, the patient will present with systemic normal, and patient will have this involuntary movement, and patient can have rash or abdominal pain. Again, our treatment will be bed rest and treatment with antibiotics, commonly penicillin, which is the cheapest, unless that person is allergic to penicillin. Another treatment that we have is aspirin. Yes, we like to not use aspirin in children, but we have two conditions where we recommend aspirin. One of those is this one, and the next one will be in Kawasaki, which we will see later on this lecture also. So they'll give you aspirin, and or they can go for mitral valve replacement if that condition persists and there is incompetent or resuscitation of blood. So again, the prognosis will depend on the extent of the myocardial involvement. Okay. And then they can give Pinoval as the transportation for that checking that is. Prevention will be, we would like to treat sore throat and we would like to give prophylactic antibiotics. If the person is going for surgery or going for any invasive procedure. Another common disease that you need to know will be Kawasaki disease. It affects the multi-system, occurs primarily in children less than 5. What you see is that there is inflammation of the blood vessels, putting them at risk for rupturing or aneurysms. Because of that inflammation, the blood vessels are so weak and can easily rupture. It can also lead to congenital heart failure because of that, platelet that is because of that inflammation, you have increase in platelet count, and that can also lead to scarring of the coronary arteries. So in other words, it leads to rupture and destruction of the rest of the arteries, coronary arteries. So what do you say? Patients will present with a fever. Sometimes the then will be fever of up to 104 on the spine. Patient also has this classic thing that is going on the hands here with peeling of the palm and the sole of the feet. Another classic thing you will notice in Kawasaki would be with that fever will also be that the eye is red. Remember when we talked about conjunctivitis, we said that the eye is swollen and red and has some purulent discharges. Same thing will present here, but there will be no discharges from the eye. The eye is red, swollen, very painful, but there is no discharges from the eye. So you look at it at first, you think it's conjunctivitis, but when you look at the history and when you look at the examination, there is no discharges from the eye. So that would be a classic difference between the two types of conjunctivitis that will present. Another classic thing would be that redness of the tongue, which can be referred to as strawberry tongue or beefy red tongue, which you look at that. So in other words, for this to be a true Kawasaki, there has to be that increase in temperature of 104 for up to 4 days, 5 or more. In addition to the beefy red tongue, squamatization of the arm and feet, peeling of the hand, sole of the hand and feet. The eye is swollen and red with no discharges, so that is conjunctivitis with no discharges. And then you can also see the rashes or the cervical node, the bladder, or are just classic. That's what you notice. Treatment, of course, because it's immune affects immune system, we like to give the immunoglobulin in addition to aspirin. And when we talk about aspirin, we are giving heavy doses of aspirin. So now we said that aspirin is contraindicated in children, but here we are kind of weighing the benefit of aspirin in this case, as opposed to the so out of 2 devils, we choose one to marry. So we choose to treat with aspirin here. And again, for you giving aspirin, what things will you put in place? What assessments will you put in place? What things will you be observing for?
Blood thinners.
Huh? Bruises, yes. What else? Yeah, what? Oh, thank you. Raise your hand. What else do you observe for if the patient is taking aspirin?
CDC or program and stuff like that.
Okay, so but what I said, but that will be an invasive because I have to draw the blood.
Oh.
Something that I don't have to draw blood on. So what will I be observing for? Who is raising their hand?
You said
What do we do besides if we're not doing blood work? What can we look for? Jackie, any idea?
increased pulse.
Increased pulse? We're not fine. Yes, Tiffany. Blood pressure? Okay, we're not fine. Who's breathing them? Okay. What's the name again?
Janini.
Janini, okay. What else?
Do you guys check to see if there's any swollen, like legs,
Arrhythmia?
or edema,
Okay.
deep redness on the legs?
Okay, redness on the hand. Think about the side effects of that aspirin. What would you be looking for? What? Tinnitus? You're looking for tinnitus, you're looking for bruising, right? Because that can put that patient at risk of bleeding, right? Okay? So you are not touching the plate, you are not doing any blood work to look at that. Neither are you putting a blood cuff, blood pressure cuff. In fact, you have to be really careful putting that blood pressure cuff. You do it as necessary because you don't want to produce any bruises on that patient. What else do you have to know? Okay.
It's not a
So you have to put it in place your bleeding precautions. Everything that has to do with bleeding precautions, you have to put that in place. Okay. So that's what you need to do for your patient. In addition to, they can also give steroids, but the first line treatment will be the immunoglobulin and the aspirin. And sometimes they give chemo agents, which is the cytotoxic agent that they will give. This patient that has Kawasaki, because it affects all the blood vessels that is the blood vessels are just very fragile, this patient needs to be seen by a cardiologist. So you put your cardiology consult, and they need to do EKG on this patient to monitor the patient and to follow up with the patient properly. You got that? So note Kawasaki because we will come and visit you. Hypertension now, we're seeing hypertension more and more in children now, as opposed to before we were saying, okay, it's only adults that will get hypertensive, but now we're seeing it's now becoming a very common phenomenon in children. Okay? But we tend to see it, we tend to believe, and we tend to say that it is a secondary problem due to a structural problem that the child has, and not a primary, cause. But most of it will stem from renal disease. Remember, we said that chronic renal failure. Okay, that will be a complication, or they have a cardiac disease, or they have endocrine or neurologic problem that can also from that to go to hypertension. Okay, but the important thing is to assess it, identify it, and follow the child properly. First line, we would like to do diet, and also we have so many kids on hypertensive medication. Some of them are taking combination medication that you will notice on the floor, but the bottom line is to choose the underlying cause and then do something to bring the blood pressure down, because we don't want that child to end up with a stroke. Same thing goes with our high cholesterol level. Again, we have to identify those kids at risk. Our first line treatment will be, of course, to restrict fatty food and direct the children into healthy eating habits. That's what we would like to do, first line. And then if no response, then we're looking at adding medication. So our medication is always our last resort that we will do, but our first line will be education and dietary restriction, and then all that. Okay? Okay. The only thing I'm saying with this cardiac arrhythmias will be, you know that of late, we are noticing, or we are hearing the news that young athletes, healthy, will go to their play football or whatever, and they'll fall, and some of them will die in there. Well, there have been issues, with this problem with, cardiac conduction in the heart. For some reason, the heart rate will just, the conduction system on the heart rate will go wacky, and then the heart rate will just fire, unnecessarily with high pace that does not allow the heart muscles, especially the ventricles, to relax and fill up and repolarize or get more oxygen and nutrients before it comes to the head. So with that sustained heart rate or arrhythmia, that can put the patient at risk of even dying. Some of them will be just that first episode that they have the problem and they will die. Some of them will recover, but especially if you see them early enough. So I just put this thing here for us to kind of, just to raise an awareness of it, that it's something that happens in children, especially young adults, that we hear of every time. But in any way, what happens is that that's one of the reasons that they have to do a good physical before they play in any football or anything. They need to be cleared, especially if they have any history of heart problem in the family. That child needs to be cleared, and the child needs to be cleared and needs to be monitored. Okay? And if there is any symptom, and the child recovers from it the first time, that child needs to be walked up completely before they are allowed to play further. Okay? So that's just what I wanted to bring up here. And for the transplant, of course, we're just taking the heart. We hope for somebody to die that has a healthy heart, and then we use it to replace the one that is defective. And that's all that you do. And then the strategy will be as you see rejection will be the problem. And of course, we were hoping to get a good match for that heart, and then we transplant it, and then we have to monitor educate them for the educational, for the medication compliance and all that we need to work on, including their growth and development. So I will stop here, and this is just telling you what we can do for a patient that has heart problem. That child must, the family, parents, caregiver must know CPR. They need to know CPR. They need to know how to monitor the vital signs, including giving the medications. They need to know what the disease problem is. And this is just like the outline of what you need to focus on when you need to treat them. And they need to know how to get resources for them, for the care of the child, meaning both case management, getting their oxygen, getting their medication, getting their food, getting from point A to point B. We need to have them, and that may involve referring them to a social worker. For the school also, we have to do this in collaboration between the school personnel. The school must need to be aware of, because some of those medications may be given at home, and the primary care physician and the cardiologist, they should also be on the case, in addition to all other specialists that is involved in that side. Okay, so let's take our break.